about annavahasrotas. Now, annavahasrotas, according to Sushruta, the Sushruta says annavahidve tayoh moolam amashayo annavahinyashtadhimanyah tatra viddasya adhanam shulo annadveshah chardhi pipasa andhyam maranancha. Now, Sushruta says annavahasrotas are two. So there are certain funny interpretations, like there are two channels to consume food, but it's not that Sushruta had two esophagus or two mouths. The basic is that the conception or the perception of the annavahasrotas is in a different manner, where the stomach, which becomes the organ where the food gets collected. So you will have one part of the gastrointestinal tract or one part of the annavahasrotas where the food is taken from the mouth and reaches up to the stomach, and till this level digestion and absorption is not a major issue. Of course, to a certain extent, very minor extent, the absorption may occur, but the major function of this would be carriage, and the food has to be having a reserve or a buffer function. The stomach is a major buffer area in the sense the energy requirement for the body is continuous. But when you consume the food maybe thrice in a day or 4 times in a day, or maybe a number of times. In between that consumption of food, the energy requirement is maintained at a uniform level, and that is the buffer action, and the stomach is a major part of that buffer action. Of course, the buffer action is taken by multiple roles or multiple organ systems of the body, so that the food energy supply is continuous, though the food intake is at spurts, like maybe once or twice or thrice or so on. Now, this function is one aspect, that the carriage of the food and buffering of the food absorption is one aspect, and the absorption of the food and providing the nourishment is the other aspect. And hence, Sushruta had considered the gastrointestinal tract in such a way that the stomach is the major central point where the functions are regulated. So when there is a need for the food, it will produce the hunger stimulus and makes you to take the food. When there is a need for the energy, it releases the food into the small intestines and facilitates the absorption. And this absorption function is carried out through the vascular system of the gastrointestinal tract. Vascular system of the gastrointestinal tract, again, mainly the superior, the inferior mesenteric vessels, and of course the gastric plexus. So these together form the annavahasrotas. So annavahasrotas has to be interpreted as the whole of the gastrointestinal tract till it reaches up to the absorptive level. Rectum and anus, which we now consider as a part of the gastrointestinal tract, Sushruta had considered them as the purishavahasrotas, where the residual portions are excreted out. But still, from our current perception, we continue to have this kind of a notion where the whole gastrointestinal tract is equated to the annavahasrotas, and we start from the mouth to the rectum. Anyway, it doesn't make a huge difference in the perception. Now, coming to the diseases of the gastrointestinal tract, the first, of course, is the common lesions of the mouth. Among the most common lesions of the mouth is stomatitis, or which we call as aphthous ulcer or mukhapaka. Mukhapaka, according to Samhita, Samsthana, Dushya, Akriti, Nama Bhedat, Ete Chatushashtividah Bhavanti. 64 varieties of the mukhapaka are possible, and they are explained in Shalakya-tantrya-bhitani tesham nimitta rupakriti-bhishyani yatha pradesham tu chaturvidhasya kriyam pravaksham mukhamesa. That's what Charaka says. So according to Charaka, there are 64 varieties of the mukhapaka. So clinical presentation of the ulcers in the mouth, or which we call as aphthous ulcers, they could be of many varieties. Now, as far as aphthous ulcers are concerned, now from the current point of view, again, there will be huge varieties of the mouth ulcers. When a patient presents with the mouth ulcers, the types could be, or causes could be, there could be multiple causes. There could be a genetic tendency, it could be food allergy, stress, hormonal factors, particularly menstrual cycle is closely related to trauma, like the abnormal teeth, or maybe accessories in the teeth, abnormal dentures, so on. So that also can result in the aphthous ulcers. And the factors which trigger this are deficiencies, particularly folic acid and vitamin B12, malabsorption, immune deficiency like HIV and so on, some of the drugs like NSAIDs. And another very common cause for this is sodium lauryl sulfate, which is one of the essential ingredients of the toothpaste as such. Now, in the current practice, we categorize these abscess ulcers, though not in 64 variety, but you will have a large number of varieties still seen there. But we classify them into minor and minor after with the size of moderate degree, and then the major minor after and major after and herpetiform after. That's how they are classified. And the size would be when the size is in between 5 to 10 millimeters of the ulcer, we call it as minor. When it is more than 10 mm, it's a major, and when it is less than 5 and multiple, then it's a herpetiform after. Usually the depth is the major after are deeper, whereas other two are shallow. Virtually, in case of minor after and herpetiform after, once they are healed, there will be no scar left over, whereas major after result in scars left over. Number, usually minor after would be having lesser number, usually 1 to 2 or maybe maximum less than 10, whereas major after also would be almost similar category. Herpetiform is usually presented as a crop and number would be quite large, usually more than 10. Then the duration, usually minor after would heal and even herpetiform after will heal within 2 weeks by themselves. They are spontaneously resolving condition. Whereas major after can be chronic, can be more than 14 days, or many times it may take a longer time. Also scars also could be formed. And comparatively, the majority of the patients whom we see in the clinical practice, they are minor after. 75 to 90% of them are the minor after. Less than 10 to 15% are major. Herpetiform are still lesser, 5% is the conditions. Now we will go into further more detail. The minor after, again, there could be further more divisions according to the pathology, as either Mikulicz ulcer or Sutton's ulcer. And the Mikulicz ulcer, usually they occur mainly in persons in between 10 to 40 years of age, and they often cause minimal symptoms, comparatively minor symptoms. Pain would be the only symptom rather, and they are small round or ovoid ulcers, usually smaller 2 to 4 millimeter diameter, and the ulcer floor is initially yellowish, but later on becomes greyish, and healing occurs with the epithelialization, no scar is left over. And around the ulcer area, there would be a reddish erythematous yellow and some edema, and they are found mainly on the non-keratinized mobile mucosa of the lips, cheeks, floor of the mouth, or at the angle sulci, or over the ventral surface of the tongue. They are not commonly seen in case of in the palate or dorsum of the tongue. They occur in groups of only a few ulcers, maximum 1 to 6 at a time. Usually they heal in 7 to 10 days, and they may recur once in 4 months or once in a month or so on, and they leave no scar as such. Typical Mikulicz ulcer is presented as a very superficial ulcer with a reddish or edema, reddish halo around area, edema, small ulcers seen in the smooth shining surface of the oral cavity, either at the buccal mucosa or in the tongue as such, in the inferior surface of the tongue or so on. And this is exactly what would be considered as a pittaja mukhapaka, and I would consider as the pitta samurcha vividha rujascha varnascha shukla runa varnavarjaha. Pain, of course, in this condition could be quite troublesome, though I don't categorize this as a severe pain, but it could be quite troublesome. And they can be easily treated with the pitta shamaka chikitsa, like Kamaduga plain or Sudhashekara or Madhyashti churna. That's one category of the minor abscess ulcers. Another category of the minor abscess ulcers are Sutton's ulcers, which are larger and having a longer duration, are more frequent recurrence. They tend to occur more frequently and more painful than Mikulicz. And they are round or ovoid like Mikulicz, they look like, but they are associated with surrounding edema. Edema is quite more remarkable than the Mikulicz. They reach large size, usually about 1 centimeter in diameter or even larger. At times they may be categorized as major aphtha. They are found on any area of the oral mucosa, including the dorsum of the tongue and palate. Unlike the miculix, which doesn't occur in those areas, certain can occur in those areas also. And similarly, they occur in small groups of 1 to 6 at one time, and they heal slowly over 10 to 40 days. They take more time often. So majority of them could be of the major category also. They recur extremely frequently and they heal with the scarring. There could be some scars seen. And usually if you see the blood picture, yes or maybe raised as such. Now typically what you see in case of a certain ulcer would be comparatively deeper. The floor would be showing a whitish color. Surrounding area, the edema is very classical. And this is one of the issue. And this is usually, I would consider this as a Raktaja Mukhapaka. It has other symptoms of Pittaja Mukhapaka, and the symptoms are more prominent, more pronounced as such. And the treatment I would prefer would be Gandhakarsa and Arogyajani Khadiradi or Khadiradi Vati given as such. With that, the patient would have somewhat better relief. Then the herpetiform ulcers. The herpetiform ulcers are comparatively rare. They are rarely seen and usually occur in the older age group or the patients who have other immunocompromised conditions. And they are most commonly seen in females than the males. And they form with some fluid containing vesicles. And it multiple minute pinhead sizes, discrete ulcers will be there, multiple ulcers, and usually they occur in the crops. And within that area zone, there will be 10 to 15 ulcers, something which resembles that of the herpes lesions elsewhere. And they involve any oral site, including keratinous mucosa. And gradually they coalesce and leave a large round ragged ulcer. Big ulcer could be formed later on by coalition of these. They heal in 10 days or longer. They are often extremely painful, recur so frequently that the ulceration may be virtually continuous. They heal and recur quite frequently. And this is exactly how you see in a herpetiform ulcers. There will be vesicles like initially there will be 10 or 15 which are present in the area, then they merge together and they form a bigger ulcer. Naturally, this I would consider as a vataja because of the acute pain and it's a sarvasaravyati which can produce a lesion throughout the oral cavity. And in this condition, I would prefer the treatment of Triphalagugulu, Arogyavardhini, Khadirarista and Tiladaila, Gandusha. With that, though the treatment has to be prolonged, and many times because of the recurrence, you will have to continue the treatment for quite a long time, they can be managed much more effectively than otherwise. Then major ulcers comparatively less common, and it's due to again a variation of either the certain ulcer or at times without any specific cause, idiopathic or familial conditions, genetic pathology, patients with the HIV or diabetes and so on, such immunocompromised conditions, patients who are on some drugs like steroids or NSAIDs. In these conditions, the ulcers can occur and they usually are quite deep and bigger, and you will have some precipitating history that may even bleed as such. There could be even bleeding. The surface would be fragile, and that I would consider as again Pittaja variety of the lesion. Raktehi, Sadahi, Tanubihi, Sapitehi, Sachitam Chapi, Pitakopa, Pittaja, Sarvasaravyati, which can occur now. These major ulcers also can occur anywhere in the body. And my preference of the treatment in that condition would be Triphalagugulu, Gandhakarsayana and Triphalakvata gargling. With that, the symptoms will be relieved somewhat effectively. Then another common condition which we see is due to toothpaste, ulcers due to sodium lauryl sulfate. Now, sodium lauryl sulfate is one of that agent which gives a foam in the toothpaste. So, every toothpaste would have some amount of the lauryl sulfate, though they claim that toothpaste is Ayurvedic and classical, no chemicals are used and so on. But to have that paste-like sensation which gives foam, lauryl sulfate would be added, though the percentage could be more or lesser. And according to the current pharmacology, lauryl sulfate was considered as an inert substance and safe substance, and FDA had given the approval under that code 21 CFRI is the code. It is given as approval as a safe drug. But practically, the incidences of the lauryl sulfate inducing ulcers are very well known, and they occur quite frequently, and particularly those toothpastes which produce more foam, they would have more lauryl sulfate, and those who have a habit of improper gargling after the brushing, so some amount of the paste and the sensation of that cold sensation of the paste is left over in the oral cavity, and some like that, and hence they do not wash off that paste for effectively, and in them the chances of this would be quite more, and usually it presents as a greyish white membrane like appearance over the mucosa, and which may be even easily removed. Comparatively, it will be less painful. It doesn't produce much pain, but in due course of time, if it is left over, it may produce an excoriation of the mucosa, and ulcers could be formed. That the deposited substance, removable greyish white membrane as such, it can result in a superficial ulcer, and usually it heals comparatively easily, but it tends to occur quite frequently. Once it becomes chronic, then it will be quite difficult to manage, and this is, I would consider, the kafaja vyadi, kanduhu gurutvam siddhavijalatvam sneho arujihi jante kapha prasekocha, kafaja vyadi, and usually my prescription would be Laghu Shekaravati, and instead of using a toothpaste, I would recommend the patients use Dashangalepa for teeth cleaning. Then, and maybe this could be used before you use a toothpaste. With that, the Dashangalepa powder to be used. With that, these lesions can be easily removed without any painful condition. Tifalakotha gargling at the end of toothpaste brushing. Tifalakotha gargling also is one of my recommendations, by which the patient would have much better result as well. Then comes the angular cheilitis, another variety of the ulcers, and the angular cheilitis, again the cause is not really known. Many times it is related to some autoimmune disorders like psoriasis or certain chemical irritations. Those who apply certain chemicals like lipsticks, different varieties of lipsticks or cosmetics which are used there. Smoking could be one of the causes, and usually patients who have lost teeth and then they tend to use some these artificial dentures, they tend to develop these angular cheilitis quite frequently. At times the reasons are not known. Typically it presents as a rough hyperkeratinosis lesions, cracks at the angular area at the lip passage, and they will be acutely painful and tends to become chronic, and gradually may extend even to the exterior, the surface also, and in due course of time there could be scar formation, and the scar may result in a reduced capacity of the mouth to open. The range of the mouth opening also could be reduced, one of the troublesome conditions, and incidence also is not very rare. It occurs quite frequently, and moreover it occurs in the old age quite frequently, and that's I would consider as a Vataja Sarvasara Vyadhi. Karkasho, Purusho, Stabdo, Krishno, Thirugamito, Dalyate, Paripatiate, Vostom, Martakopa, Vataja, Vostavyadhi. And the treatment I would prefer would be when you know the exact underlying disease like psoriasis or so on. A specific treatment for that condition could be good enough. But when you are not able to make out that, my usual prescription would be Kaishara Gugulu, Sarivadhyasava, Avipatigarchurna, or occasionally if the condition becomes resistant, doesn't respond to the usual treatment, a course of Vilachana can be quite helpful in such conditions. Then another very common incidence of conditions which we now see is nicotine stomatitis. Nicotine stomatitis usually those who smoke or those who chew tobacco or any other tobacco products like Jarda and so on, they tend to present with them the nicotine stomatitis, or it's also called as a smoker's palate. Characteristically in this condition, the whole palate would be having either change in the color, and the mucosa become atrophied, and it looks like the whole palate has lost its luster. At times there could be some eruptions over the palate also, small fine eruptions also over the palate, and The clinical symptoms would be there may not be much pain, rather the patient would have some discomfort in swallowing, dryness in the mouth, and the patient may not be able to appreciate the taste of the food often, and it's also considered as a precancerous condition. Maybe later on, submucous fibrosis can be one of the consequences of the nicotine stomatitis, so these have to be carefully seen. Typically, in the presentation is compared to the talupaka, particularly vataja or pittaja. Shoshotyatun dirijapi talu shwaso vata talu shoshasa pittata pittam kuriyat pakam atyartha goram talunyanam talpakam budanti. At times it can result in a pus formation. In that condition it's a pittaja, otherwise it's a vataja talupaka. And the clinical features otherwise mentioned in other samhitas are same krishnarunam, that blackish color, and nishpatanam sashitam prasramsana aspandana toda bhedaha, reduced sensitivity of the palate area, krishna jara sfotak taldaha, dhumayanam chapi avadirnata cha. Cracks are the other signs typically of the vataja variety. That sita vijjalatva, dryness, is also one of the features. Treatment, of course, the prevention of the nicotine contact is one of the important issue of the treatment. If you do not do that, none of the treatment can help. So either it is smoking or chewing of the tobacco, that has to be clearly avoided. If not, there is no question of a cure there. And the major risk of the possible malignant conversion is one of the risks there, which is unpredictable. So this has to be explained to the patients properly. And when I prescribe, I usually prescribe Arogyavardhini, Agnitundi or Kamadika, depending upon the patient's presentation. If the patient has more burning sensation and the reddish color over there, Kamadika is usual prescription. If the patient has comparatively more pain and impaired appetite and so on symptoms, then Agnitundi would be the better prescription. Bunimbadikwata and Tripalakwata gargling, which can help in maybe reducing the symptoms to a great extent. And once the condition becomes atrophied, there may not be a reversal, it has to be lifelong. Another of the rare condition which we may see is a smoke melanosis, which also is a similar category. It's a rare condition where particularly this occurs in patients who have the habit of reverse smoking. Reverse smoking is the inflamed or the cigarette, which end of the cigarette which has set a fire is kept in the mouth and then you smoke from within. This kind of habit exists in some people and they are more prone to develop this, and this also is one of the major risk factors suggesting of possible malignancy, and it occurs rarely. Then comes the candidiasis, another of the condition which we often see, particularly in the patients who are bedridden, who are on antibiotic therapy for a long time, and patients like stroke patients, we often see these candidiasis quite frequently. Patients who have immunocompromised conditions also, or patients who have dentures and the hygiene of the dentures is not maintained. Smoking, of course, is one of the causes for that, and such conditions would be presented typically as multiple sticky whitish surfaces over the tongue and oral mucosa throughout anywhere. And usually the deposition of these fungal bodies, yellow, whitish, sticky substances, they are more over certain zones. They will have a distribution. At some areas they are more. And once these lesions, these soft lesions are denuded, they are left out, the tongue or maybe mucosa shows inflamed signs, even there could be atrophy. And it's a condition which is quite troublesome. And in all these conditions, it's quite important to identify the underlying pathology. That underlying pathology, like either impaired systemic conditions, hygienic factors, they have to be taken care of. In patients who are bedridden and paralytic patients, mouth gargling would be necessary, and often we may use a hydrogen peroxide for mouth gargling also, so that the condition becomes cleaner. And if the patient has immunocompromised condition, that has to be treated. Prolonged antibiotic use has to be avoided. So that's all the important thing. Now, once we have taken those precautions, then to facilitate the healing, I would prefer Gandhakarsayana, Kamaluka, Manjistadi or Khajilarista and Triphalapatha gargling. With that, many of the conditions may show significant resolution. Then another of the very troublesome condition is oral submucous fibrosis. Oral submucous fibrosis is a condition where the patient would not be able to open the mouth properly. In the majority of the conditions, this is related to the tobacco chewing. Patients who have the habit of tobacco chewing, they tend to develop the fibrosis, submucous fibrosis, where gradually the mucosal membrane would be losing its luster. It's the next consequence of the nicotine stomatitis, and at the same time the collagen tissue becomes constricted, and hence the stretching of the mouth becomes difficult. It could be at the angle of the mouth, or it could be over the surface of the tongue, and the tongue movement also becomes diminished, or the whole of the oral cavity opening, it may become restricted and the patient may not be able to open the mouth properly. And this is typically described in the context of Mukhapaka. Karoti vadanasya antaha pranan sarvasaraha nilaha sancharito arunan rukshan vosto tamro chalatvajo jihva shita asaha cannot tolerate the cold. Guru is putita kantakachila virunati sakrachena mukham. The patient would not be able to mouth properly. That's that's submucous fibrosis. Of course, submucous fibrosis is a purely irreversible condition that it cannot be reversed completely, and it's always having a high risk of becoming malignant. So these cautions have to be taken, and tobacco chewing habit has to be avoided. But of course, submucous fibrosis also can occur in non-tobacco chewers occasionally in genetic pathologies. In such conditions, of course, you do not have much to do there, and the usual my prescription would be Kaishwara, Gandhakarsayana, Magister, Rikvata and Tiladela Gandusha. Prognosis is poor, and assessment of the submucous fibrosis is inability to open the mouth. That range of opening of the mouth is the criteria by which the degree or grades are decided. Then rarely you may see another of the condition called as contact stomatitis. Particularly this occurs due to contact with the cosmetics like lipstick and so on. So the persons who are allergic, it's something like hypersensitivity due to allergy only. There would be a typical history of the contact of using certain new brand of lipstick and so on, and there will be eruptions and peels, swelling, acid. And in these cases, the history is quite classical, and avoiding that allergen is one of the important issues. And the usual treatment I will prescribe is Labsul Shekara, Kamaluka and Manjista Dikvatha. Then another type of the ulcers which are quite troublesome would be the eosinophilic ulcers. They are usually deep-seated ulcers, and usually they occur as a result of gastrointestinal tract pathology, or it could be due to some previous injuries. Either it could be injury which occurs in the mucosa due to trauma, or some sharp-edged teeth or food. Again, commonly patients who have some dentures which can produce injury, and the neonatal teeth also, natal teeth which rarely occurs, which is also called Legapeta disease, abrasion with toothbrush, and dentures, orthodontic occlusion appliances, so on. Injuries due to any accidents, they tend to become chronic, and the ulcer looks like a very deep ulcer with the slough, and often it may produce some confusion with the malignancies. But when you palpate, typically eosinophilic ulcers would not have much induration, whereas a malignant ulcer may have a induration. Many times it may not be possible to make out clinically, so biopsy may be required. So deep ulcers with the slough containing lesions are either eosinophilic ulcers, or they could be the malignant. Now once it is confirmed that it is eosinophilic ulcer, the usual treatment would be you have to avoid further trauma, like if there is a denture injury that has to be avoided. Then once it is done, usually my prescription would be Arogyavadini, Kamaluka and Sarivadhyasa. Usually with these patients would have a better healing. Denture stomatitis is one of the variations of the same eosinophilic ulcers, like due to the dentures there could be impression of the denture, that improperly fitting dentures, there could be irritation over the tongue or maybe the palate, and you may see the typical impressions of the denture. And once we have make out that part, the diagnosis is simple, and the treatment, of course, there is no need of medical treatment. All that the source for irritation has to be modified. That denture has to be modified. A new denture has to be used. Then another of the condition which we may often see would be chemotherapy-induced oral lesions. Patients who are on chemotherapy, they may present with either hairy tongue, which is also mucositis, or it's erythematous mucositis, where there could be reddish area, or ulcerative mucositis. Mucositis, inflammation of the oral mucosa due to chemotherapy, is a very common condition. Most of the times it occurs when the patients are on prolonged chemotherapy. First or second sitting may not produce this, but the consequent sittings often produce this, and quite troublesome. Patient would not be able to take the food, swallow the food, enjoy the taste also. And majority of these conditions are reversible, in the sense once the chemotherapy is stopped, these will recover completely. But during that, the pain management is better with the Tilatela Gandush and Kamalvarasa. Of course, chemotherapy for the purpose of which specific purpose that may have to be continued. I don't say that it has to be interrupted. Another of the condition in the oral cavity which we see quite frequently is the leukoplakia. Leukoplakia is also a precancerous condition where the patient would have a whitish plaque-like lesions at the oral cavity anywhere, either smaller or bigger, and they may have a typical border seen or they may not be a typical border. And when you palpate, you can feel that difference. The consistency of that area, leukoplakia, would be totally different from the mucosa. That will be somewhat harder consistency. Harder the consistency, the possibility of malignancy would be more. Or at times it could be verrucous. The surface could be like irregular, rough as such, and projected, polyp-like. And this, I would consider this as the vrunda, ekavrunda or vrunda. Vruttanado yashvaitushadaha kandanvido apaki amruduhu gurushta amruduhu. That firm consistency is a characteristic feature. Namna ekavindah parikritha savyadhi balasak shate prasudaha. It is due to kapha and rakta. If the surface is raised, then samunnatam vruttam amandadaham tivratjuram vrundam udaharanti tam chapi pitta kshatrya kopa vidyata. Now, in all the leukoplakia conditions, a possible study is necessary to confirm whether there is a possible malignancy or not. And to confirm whether there is a possible malignancy or not, biopsy is the ultimate. But before we go for the biopsy, risk prediction is one of the issues. Risk prediction is when the patient has a verrucous type, like a rough surface, then the risk is higher, and erosion and ulceration within the lesion is also suggestive of malignancy. If there is a nodule indicates a malignant potential, lesion that is hard in its periphery is also a predictive of malignant changes. Lesions of the anterior floor of the mouth and under surface of the tongue is strongly associated with malignant potential. So risk of the malignancy is assessed clinically but finalized with the biopsy. So biopsy is necessary. Suppose the biopsy is negative, and in such conditions, my prescription would be Tipulagolgam Darsana Khadara Arista and Tipulakodgarpi. Results, I don't say that a leukoplakia can be completely cured, but the symptoms can be reduced significantly. And as far as whether the patient would have a absolute patient would be free from the malignancy risk or not is again unpredictable. It's better to have repeated biopsies in due course of time as the patient is followed up. If the leukoplakia gets resolved very rarely, okay, fine. In that condition, there is no need of repeating it. Otherwise, repetition is necessary. The verrucous leukoplakia appearance would be, you will have a rough projective, this whitish surface, making it rough appearance. Then hairy leukoplakia is one more of the issue, where there could be leukoplakia with the hair-like appearances seen, which is often produced due to immunodeficiency like HIV or diabetes. HIV, very commonly HIV, and there is no question of any specific treatment for that. Erythroplakia is one more variant of the leukoplakia. Instead of whitish, the lesions are reddish, and these reddish raised surfaces seen, they are mostly pre-malignant, and they have to be, again, biopsy is absolutely necessary, and if it is malignant, the protocol of malignancy treatment has to be followed. Lichen planus is one of the other condition where patient may have a systemic lesions of the lichen over the surface of the body, and the tongue also, oral cavity also shows that. And lichen planus lesions are seen as wide areas of erythema with maybe some slough, and even the gum may be involved in that condition. And the treatment protocol would be as in case of the lichen planus elsewhere. Lagzurshekara, Gandhakarsana, Khadirarista is the usual prescription which I do. But lichen planus of the oral cavity also has a high risk of getting malignant. Malignant changes are quite high, and it is considered to be around 8%. 8% is around that condition. Then lupus erythematosus is another rare condition which we say patients who have lupus SLE-like conditions. They may have the pathology in the oral cavity also, which may look like there could be collagen tissue constriction, something like a submucous fibrosis lesions like appearance may seen, but along with that there could be deep ulcers. There is no question of a specific treatment for the oral lesions, but they may help in diagnosis of SLE, and the treatment protocol would be as we treat for SLE. There is absolutely no question of cure for that. The usual my prescription would be Kaisharu, Lakshutshekaravati, and Manjistatipata, Manjistatic Sharabasti, Agnichikitsa, depending upon the other clinical symptoms. So SLE is a palliative treatment. Rarely you may require steroids. Pemphigus is another of the condition where the oral cavity may present with multiple lesions. Again, the diagnosis is based upon what we see in the periphery. The pemphigus is a generalized systemic condition. Over the surface of the body, you will have multiple vesicular eruptions and sudden onset and rapid course. In the oral cavity, there would be complete erosion of the mucosa, multiple erosion spots and fragile. There could be bleeding also, quite difficult to swallow, and these conditions are again difficult to manage, and glucocorticoids would be absolutely essential. And along with the glucocorticoids, my prescription would be Kamaduga, Triphalakvata, but pemphigus as such is one of the difficult conditions to be treated. Chickenpox also can present with the oral lesions. Typically, scattered vesicular eruptions can occur, and they have to be differentiated. And there again, there is no specific treatment for the oral chickenpox lesions, except maybe symptomatic treatment where we may give a Madhyasthi. But otherwise, it is the same treatment for the systemic lesions, chickenpox lesions like Paripathalikata, Arogyavardhini, and Mrityunjaya is a usual prescription. Another rare condition is a Behçet's disease, where there could be a systemic involvement. It's a variant of autoimmune disorder, a sort of variant of SLE-like condition, where the lesions can be presented throughout the body, and in typical Behçet's disease, there will be every organ will be involved. Psychological functions would be affected, nervous system would be affected, eyes also would have the same lesions of deposition, along the genital warts also, maybe genital area there could be again lesions, ulcer, superficial ulcers can see in skin also would show the lesions, and in that condition oral cavity also, tongue also may show the lesions. Treatment, of course, there is no specific treatment for the oral cavity lesion. The important is the oral cavity lesions could be the factors by which the systemic disease could be diagnosed. That's all the point. Now, these may be considered as the Vishamadvara category, and my prescription would be like the treatment of Vishamadvara. Nidra Rasha, Brahma, Shwasa, Tanda, Sukta, Gatarji, Krishna, Moho, Madaha, Stambha, Daha, Shitam, Sudivita, Pakti, Chirena, Doshanam, Unmadaha, Shavadantata, Rasana, Krishna, Sandhi Murtasila Rujaha, Nirpukni Kalashanete. These are all the typical features of the Vishamadvara, where multiple organs are involved, and usual main treatment would be Lakshmi or Dhatgata Dvara, particularly Vishama Dhatgata Dvara. And main treatment would be Lakshmi Narayana Arogyavardhini Amrita Agnichikitsa Ksharabasti, as we treat any of the Dhatgata Dvara. One more of the condition which we see is the burning mouth syndrome. Burning mouth syndrome would be again of three categories. The type 1 is where the patient would have symptoms, have no symptoms in the waking condition, and only in the night time the symptoms are variable, and often it may be due to nutrition deficiency. Diabetes also may be one of the causes, quite commonly seen. Type 2 is where the patient may have continuous burning symptoms throughout the day and night, and usually it's related to anxiety during examination and so on. Then burning mouth intermittently occurring, usually due to food allergy. When you consume some irritant food like pizza and so on, or maybe this gobi manchuri, like spicy food, often can result in that situation. So in that condition, it could be a pitta alpaka variety. Of course, in the type 1, there is no specific treatment for that. Diabetes management will be the issue. Type 3, the identification of the causes is important. Type 2, which is anxiety induced, can respond very well to Sulsagara, Kamaduga, Godanja Vipatigara. Then comes the carcinomas, oral carcinomas. Oral carcinomas are of different category. Among them, the most common are the squamous cell carcinoma. And that's the typical of the Arbuda description. And the Raktopushasya Rudiram Sarvata Shonata Prabhu Kharjura Sadhusham Tatra Kshine Rakte Arbudam Veta Antak Kapalam Shava Pandu Kapar Budam Kuriya Tad Ghatiram Chinnam Mrididam Chibivirtire. Squamous cell carcinoma are the more common, and they may either present as deep ulcers which do not heal, or they may present as a lump, or they may present as excoriations. That may be localized lump could be also the presentation there. So oral squamous cell carcinomas, locations of this, when you examine a patient, it is quite important to possibly locate the lesions. The possible locations of the frequent oral malignancies are either at the angle of the lip with the gum, or at the gum itself, or it could be again at the lip over, and at the buccal mucosa, at the vestibular area, hard palate, and over the tonsillar area. Tonsillar area also is one of the areas where they occur quite frequently. Ventral surface. So every part of the oral cavity has to be examined properly before you rule out any tumor pathology. Incidence of this is again more common in males in the mouth and the tongue, and females comparatively less common as such. But now it is known that there is a gradual tendency, increasing in the tendency of this oral malignancy to occur. The general, some comprehensive facts about the oral malignancy is average 5-year survival period of oral malignancy is just 50%, even after all the well-known treatment as such. Among the known risk factors, cigarette smoking is most, and use of pipes, smokeless tobacco, etc. They are known causes which can produce this. About 95% of all malignancies they occur relatively at a younger age of 40 years of age. And average age at the time of diagnosis is about 60. So it is usually diagnosed quite late. And the high risk profile of the oral cancer is tobacco chewers and alcohol. There is a gradual change in the tendency. Earlier, in 1980s, the ratio between the male and the female was 6:1, whereas now it has become 2:1. So incidence in the females also is increasing rapidly as such. That's about one of the condition. And of course, in such conditions, I don't suggest any medical treatment. It requires all the other treatment like either surgical or chemotherapy or radiation as per the protocol, and the prognosis is extremely poor. Then the other condition which can produce some confusion with the malignancies are the non-genital warts or verruca vulgaris, the warts in the oral cavity, which may look like typically localized masses and often produce a confusion with the tumor. Confirmation is always done by the biopsy, usually painless, but they may get injured during chewing activity and hence there could be bleeding. They may show that typical appearance of whitish, somewhat firm keratin tissue deposit over there, as in case of any other warts. Important is to differentiate it from the tumor pathology, and the treatment usually my prescription will be Kaisharubukularaverdini for prolonged duration. Then another is 4D spots, which is really harmless virtually, and again the patients who tend to have the habit of using lipsticks quite frequently, the mucosal surface may show some areas of hardening, a slight change in this, and it may look like dry, and these are called as 4D spots, usually due to the result of cosmetics. And virtually there would be no pain, nothing there, but except that cosmetic appearance would be the issue. And in that condition, there is no question of any medical management. The treatment would be electrosurgery or vaporizing laser treatment. Then another very rare condition is the papilloma, where benign lesions of the oral cavity, particularly tongue, you may see prominent polyps. There is virtually no curative treatment and they are asymptomatic and they do not require any treatment, but important is they need to be differentiated from other possible conditions. Then one more of the condition of some significance from the clinical point of view is a Plummer-Vinson syndrome, where the tongue becomes bald and the patient would have a difficulty in swallowing. It's a consequence of the anemia. Patients who have iron deficiency anemia, there could be tongue becomes bald, or there could be a pseudomembrane like projection at the area which makes the patient present with the swallowing difficulty. Typically it's a swallowing difficulty is the presentation, and bald tongue or maybe a pseudomembrane like projection seen, and the patient would be classically anemic. Iron deficiency anemia is the basic cause for that, and these are typically the presentations of the complications of upadrava of the pandu. उपद्रवः स्तेषुरुचि पिपासा छर्दिः ज्वरः मूर्धरुजा अग्निसाधः शोफस्तथा कण्ठगतः अबलत्वं कण्ठगतः शोफः. Now in that condition, as usual, the treatment would be for the pandu, and my prescription would be Punarna-Mandora Chandraprabha Draksharishta as well from the presentation. Pellagra, or the deficiency of vitamins, is another of the condition where tongue may become bald, or even there could be skin lesions, typically poor appetite, diarrhea, skin lesions happen in children, and the patient may have neuropsychiatric symptoms also, which is considered to be deficiency syndrome, pellagra, vitamin C deficiencies, and the treatment would be Aragyavardhini Kumaryasa is a better treatment. Comparatively rare now, these days incidence is rare, occasionally you may see that. Geographic tongue is another of the condition where the whole surface would be rough, tongue surface would be rough, and you will see that the areas of some areas of denudation, as if there are the maps of the geography drawn over there, and that's why it's called as geographic tongue. Often it is due to psoriasis, or many times drugs or immune mechanism. There is no again definite curative treatment. The only treatment by which you can patient somewhat improve would be dietary advice, where the irritant food substances are avoided, and Tiladela is other feature. Fisher tongue is another condition. Many times the causes are not known. Often it is due to the diet, spicy food, painful also occasionally, where the tongue gets cracked over the area, and virtually there is no definite curative treatment. Tiladela Gandusha can help to a certain extent. Then the other rare conditions are pigmentation disorders, where there could be oral pigmentation over the oral cavity. Either it could be melanosis, where spots could be there, or at times it could be due to the chemicals which are used in the dentures, or the scars may become melanotic. In all these conditions, quite important is to rule out a malignancy in that condition, otherwise there is no need of treatment. The patient may present with blackish spots areas. Comparatively the incidence is rare, very rarely we may see such patients, but important is you palpate if there is an induration, then biopsy is necessary. If there is no induration, no change in the consistency, it can be just left as such, which may be considered as a simple pedicure. Nevus is as usual, the nevus as you occur elsewhere in the body, in the oral cavity also it can occur. Virtually there is no need of treatment there. The only thing is it has to be differentiated from the possible melanosis or melanoma as such. Then amalgam induced pigmentation is another of the causes. Patients may present with the pigmentation in the oral cavity due to the amalgam filled into the teeth during treatment. There again, there is no question of any curative treatment. The important is to make out patients who tend to present with that blackish color over the oral mucosa, and near the tinctures where they have used these amalgams, it could be one of the causes. No question of any curative treatment. Malignant melanoma is which also can produce the confusion, but typically it presents with the indurated area, or even can be ulcerated. Prognosis is extremely poor in such conditions. With this, and of course, one more of the condition related to the pigment would be the Peutz-Jeghers syndrome. Peutz-Jeghers syndrome, where the patient would have multiple black spots in the oral cavity, and they tend to develop polyps in the intestines. and these are together, which is a Sahaja Arshas Lakshana. So patients with the oral cavity pigmentary lesions, you will have to take a detailed history, or if necessary go for the investigation to confirm whether there is a polyp or not. And the polyps, at times these polyps can be symptomatic. Intestinal polyposis can be symptomatic, where the patient may have bleeding and which requires more attention than the oral lesions as such. With this we will wind up today. And of course the risk factors, the oral Peutz-Jeghers syndrome, it may result in cancers, and the risk factors are more in different areas of the abdomen. The malignancy could occur, and most important is esophagus, stomach and small bowel. That's about the Peutz-Jeghers syndrome. With this we will wind up today. We will continue in the next session. If there are any questions, I will try to answer. And right, there are no questions, so we will wind up today.